let's see, our guest today is Erin Telegdi, RNBA, MSc. As I mentioned, I'm pleased to work with Erin again. It's been a while. I'm excited that she's taken up this line of work. It's a challenging area to work with, not just with this specific population, but also to work with them during COVID-19 and the isolation that's around it. So Erin works at Moss Park Consumption and Treatment Services, a satellite program of South Riverdale Community Health Center in downtown Toronto East neighborhood. Now, I know we have these services right across Canada, so I'm hoping you can all relate to her experience. She also works at Women's Care Clinic at the Women's College Hospital in Toronto, and she works in the inpatient program at Casey House Hospital, which I believe is with HIV patients. Mm-hmm. So, Erin, welcome.
Thank you so much for the lovely introduction, Heather. And before we begin, I want to acknowledge that I work and live on Treaty 13 territory, which was established between the Mississaugas of Credit River of the Anishinaabe Nation and the British Crown, and further acknowledge that I am surrounded by Treaty 13A, Treaty 20, also known as the Williams Treaty, and Treaty 19. I acknowledge the Wendat and Haudenosaunee people that also occupied this territory. This territory is the subject of the Dish with One Spoon Wampum Belt Covenant, created between the Haudenosaunee Confederacy and the Anishinaabe, including allied nations, to peaceably share and protect the resources around the Great Lakes. I acknowledge that we are all treaty people, and I say this to honor the land that I work on, the people I work with, and my responsibility as a settler healthcare provider to the collective work of decolonizing the healthcare system. So thank you to Wounds Canada for this opportunity, and I'm excited to talk about some stuff I'm really passionate about.
I'm excited to hear from you too, Erin. I know you have a lot to share with us, but before we get started, I want to find out who's who at the zoo. If any of you know me, you know that line. So let's just poll our audience for a little bit and find out, first of all, we've got about 7 polling questions throughout. First of all, what kind of setting do you work in? So we want to know who you are. So what I want you to do now is to click on the best one, and is it enter they push? And click submit. That doesn't mean you submit. You submit. You're not submitting. Okay, I got that straight. All right. And Olena is in charge of the polling. Oh, wow. So we have 14%, Erin, that's working in harm reduction, 67 in community, Yay. 2 in 3 in admin, and 14 in others. So interesting. We do have the harm reduction community represented.
Yay.
That sounds good, eh? Okay, let's go on to the next polling question. Do you work with people who use injection drugs? Yes, no, or unsure? Okay, how are we doing? Remember, there's no right or wrong answer. You just have to tell the truth. Wow. What do you think? Yeah, I think we've got the right people here. Okay. And you know, interestingly enough, there was an unsure in there. Comfortable working with people who use injection drugs? Yes, no, sometimes, or unsure. Don't touch your screen, people. Just sit and absorb. Okay, let's see what the response is here. Oh, good. 62%. 62% feel comfortable working with people who use injection drugs. Perfect. Okay, let's go on. And now I'm going to turn it back over to Erin. So, Erin, what got you? Last time I worked with you, you were an admin assistant. With, was it Wounds Canada and IIWCC, both?
Yep.
With both. And now here you are, a nurse. First of all, first question, what got you out of admin and into nursing? And second question is, what led you to work with this population of people that are so vulnerable right now?
Yeah, so, I mean, some days I wonder why I got into nursing. It's healthcare is certainly a very challenging field, but I think, you know, it's kind of in my blood. My mom's a nurse, my aunt's a nurse. And, you know, working with Women's Canada, I was working with nurses all the time, including you, Heather, and seeing the really, just like the power of the work that nurses can do in the healthcare system. So I did end up taking that route, and I graduated in 2013 from U of T. And I initially started working at KCS Hospital, which is a specialty hospital for HIV care in Toronto. And I think a few of my KCS people are on the webinar, so hi to you all. And I think, you know, in 2017, we were seeing across Canada that there was really like an overwhelming surge in overdose deaths. And a lot of us feeling that the government was being very slow to respond in terms of opening supervised consumption services and other kinds of policies and programming. So in August 2017 in Toronto, a group of harm reduction activists opened an unsanctioned supervised consumption service or overdose prevention site, which is pictured here. And they put out a call for RN volunteers because they kind of had this arrangement with the police in Toronto where the police said, we won't shut you down, but there are certain conditions for that. And one of the conditions was that they always had a nurse on site. So I'd never responded to an overdose before, but I thought this was a movement that I felt was just. So I started volunteering regularly, and I got more than I bargained for in the best possible ways. I think the Moss Park community, like, they're just the best, kindest, funniest, smartest group of people. So when the site was adopted by South Riverdale Community Health Center to be a sanctioned site, they asked if I'd be interested in coming on as an RN, and it's been my pleasure to work for this community for the past 3 years.
Excellent. Well, just to name drop a little bit, your mother works for the Ontario government as a nurse, and your aunt, who many of you on this call know, is Pat Coots. So yeah, you've got good genes there, my dear. Oh. Good genes. So maybe you want to tell us a little bit about the CTS.
Yeah, so it's a good question, especially for anyone who's not from Ontario, because this is a very Ontario-specific term for what we sort of more broadly understand to be supervised injection services. And there are about 50 of these across Canada at this time. So it's a healthcare service where people can inject street drugs free from the risk of fatal overdose or police interference. And we provide services such as overdose prevention response, social services, healthcare services, and other wraparound services and programming. And really all the sites share in common kind of a harm reduction approach to care.
So a harm reduction approach to care means what? Let's ask our audience. Does a harm reduction service enable drug use? True or false? Okay. Well, let's have you comment on that. This is 78% said false, 22% said true. So let's discuss what.
I'm speaking to a friendly crowd for sure. So I think we know already that what harm reduction enables is people to stay alive and be healthy. And the kind of point of this presentation is to sort of unpack that idea a little bit. So what is harm reduction? The most important thing, it's a philosophy of care developed by people who use drugs for people who use drugs. Yeah. And a harm reduction approach means that service providers meet people on their clients' terms without judging their drug use or requiring them to change. It's a philosophy focused on working to meet people's personally defined goals and needs, and understanding that systemic barriers such as poverty, racism, criminalization, and colonialism cause much greater harm in people's lives than drugs themselves. So it's an approach that says we love people who use drugs and they deserve to be happy and healthy. And it's a philosophy that's been around for a pretty long time, but I think the healthcare system has only more recently started to get on board with this. And I generally think, you know, people who use drugs are the best people to talk about harm reduction because it is their movement, but I think there's also value in being able to talk kind of like healthcare provider to healthcare provider about this, because I think we still have a lot of work to do in the healthcare system in order to be providing that competent, compassionate care that people deserve.
So you're looking at this, and just correct me if I'm wrong, you're looking at drug use as more, we've got somebody who's playing, there's more lines coming on the screen. You're looking at it more of a symptom of a problem rather than the problem. Is that what you're saying?
Well, harm reduction asks us to really look at the context of what's going on in communities and in people's lives.
Exactly. Okay. So, all right. I want you to take me through what it's like a day in the life of you. You know, this is like qualitative research where you get the phenomenological aspect of who you are. So, Moss Park Consumption and Treatment Service. What's a day in the life of Erin when she goes to work?
Yeah, so as I talk about this, we'll have kind of a bit of a tour of the space, although some folks on the webinar have been here. Many have not, I'm sure. So this is kind of like our storefront. We're just right across the street from Moss Park, that kind of Queen and Sherbourne in Toronto, if you know the city. And it's pretty unassuming. Like you could be walking past a bakery or, and in fact, the space was an art gallery before we started renting it. And then that's kind of sort of the inside, space where people initially walk into. And it's pretty open, bright, friendly.
So what are the buckets for? What are the buckets and the baskets for?
Yeah, so some people just come in to get supplies. So those buckets have safer injection kits, they have safer smoking kits. Some people come for naloxone kits, and we're always happy to do kind of naloxone training for anyone who comes in.
So they might just come in, grab what they need, and go back out?
Yeah, for sure. So we operate 12 to 6 currently, Tuesday to Sunday, and it's an injection service and a drop-in service for people who use drugs.
No, we talked about using injection drugs, but they also come in if they are taking other drugs as well, correct?
Yeah, so by and large, people are injecting, but we also have people come in to snort their drugs, or you can take them orally. And our site does not have kind of the exemption to permit smoking of drugs. And I think there's only one site in Canada that has kind of that infrastructure in place where people can smoke drugs as well as part of the supervised consumption service, but not us at the moment.
Okay.
So just a bit about our team, because there's a couple team members here. We're a mix of nurses, but also community health workers who kind of do more of the programming and formal social service work. And also—
Can you get a bit closer, Erin, to the mic? Yeah,
and also overdose response workers. So most people on the team, kind of whatever role they're in, have lived or living experience of drug use, which means most workers have previously used drugs or currently use drugs. And several of our workers started out as service users, which I think is so important because people who use drugs are the experts in their own experience, so their voices are really important. And just to give a bit of a picture of who our clients are, or our service users, they're generally young. I think about 35 is the average age. Most are homeless or precariously housed. Most are criminalized and involved with the carceral system. About 50% are Indigenous, about 2/3 are men, and 1/3 are women. And we see approximately 80 to 100 people per day and have a core group of about 300 regulars.
Wow, wow.
So on the average day, I mostly spend time in the injection space. So in the injection space, we support with overdose response, and that's not just nurses, but all the workers. But this is also where people generally will connect with me if they have kind of other healthcare needs that they want some support with. So we do have an on-call nurse practitioner, so we're able to get scripts and requisitions as needed. And because, you know, funding has been so precarious, in harm reduction, it's been a challenge for us. But one thing we're really trying to work on now is increasing our clinical capacity so we can really be providing as many services as possible to people on site. And just for anyone who's not familiar with street fentanyl or illicit fentanyl, this is a picture of it. It comes in all colors of the rainbow, at least in our neighborhood of Toronto. And it's overwhelmingly the drug of choice for folks who access our service. It's the most available opiate on the street, and it gets dyed these bright colors, partially for marketing purposes, but also harm reduction, so that people don't kind of mix up drugs. Like, you don't want to confuse your fentanyl for, you know, cocaine or crystal meth. So it's also a bit of a harm reduction strategy.
Okay, another question. People who use injection drugs are not able to care for their health. True or false?
Yay.
Are you happy? Are you happy, Erin?
Mhm.
It's nice when you're speaking to the choir, right?
Feeling lots of love.
Yeah, feeling lots of love. Well, let's take a look at some health issues then. So
Yep.
let's start. I mean, obviously, we're Wounds Canada and we focus on wounds, but I like to say we focus on the wounded. So let's talk about what you do when it comes to wound care.
Yeah, so I mean, obviously, this crowd knows that just by walking through the door, people are like caring about their health. And I've really found folks to be so engaged in their health and the health of their community. And so we deal with like any kind of emergent, acute, or chronic health care needs. We do some case management. And about 50% of the nursing work that we do is skin and wound related, which I think is pretty consistent with other community nursing kind of work.
Yeah, yeah, for sure. And so this is a nice breakdown of your population.
It's a very crude graph that I drew up to kind of break down the kinds of skin and wound care things that we see. And hopefully, you know, it's obvious the majority of what we see is abscess and cellulitis. We see a smattering of other kind of wound issues. But I think, you know, because our folks are pretty young and they're very active, we don't see a ton of diabetes, don't see a lot of hypertension, just kind of any of those other kind of comorbid or comorbidities we're just not seeing because of the youth of our folks.
And are the abscesses and cellulitis mainly related to injection sites?
Yeah, I mean, it's hard to say at any given time if it's necessarily related to an injection sites, because certainly things like food insecurity or malnutrition or just the conditions in which people are living like aren't necessarily always hygienic. Certainly in shelters are people sleeping rough. But I would say yes, like certainly injection drug use is a risk factor.
So bringing it back to what you just said, your service also provides nutrition and showers, etc., doesn't it?
Not showers, but
Not showers?
we do try to provide food as much as we can to folks, for sure.
Okay, I wasn't sure about that. Thank you. Okay, so based on the wound bed, I'm losing my mind here. Based on the cycle, the wound prevention and management cycle, what is a plan of care, a typical plan of care like? I mean, the wound prevention and management cycle, unlike the wound bed prep model, just FYI for people that don't know the difference between the two, the wound bed prep model was designed by plastics to prepare wounds for flaps, grafts, whatever. And over the years, Wounds Canada and many others have modified it. However, we never really felt we were addressing the true needs of the person. So by bringing the wound prevention and management cycle forward, we're hoping that it improves the needs. So what's your experience working with this in your community?
Yeah, I mean, I think the beauty of this model is that it mirrors quite well the work that we do in harm reduction and in supervised consumption services. And really, it's that focus on steps 1, 2, 3, and 5, like really looking at the context of people's lives and really trying to mobilize resources around food security and housing, access to hygiene services, that all of these things really make the difference between, you know, barriers or facilitators to wound healing.
Yeah, you know, I used to tell students, you know, if you haven't addressed those issues, you may as well put peanut butter on it because nothing's going to work. You know, it won't work unless you've identified not just the causes, but all of the cofactors. And are they able to do it? You know, you can give them a great plan, but are they able to do it? So let's look at some of your cases that you brought forward.
Yeah, so I think just to start out looking at some, you know, abscesses and cellulitis. This woman ended up with a cellulitis that was kind of related to reusing a syringe for, you know, a day or two. And she was on antibiotics for the cellulitis, but she was coming to us daily for wound care. And there's really not a lot going on underneath that cling. But, you know, we were doing the wound care for her every day. And the value of that was really like just having the space to have conversations about safer injection techniques, support her with vein finding, and those kinds of things to try to help, you know, prevent this complication in the future?
Well, I see all the drawings on her arm, so my assumption is that that's where the cellulitis was at one point before you initiated antibiotic therapy. Is that correct?
Yeah. And so it's gone down quite a bit by the time this photo was taken.
Yeah, significantly.
So this is a photo of an abscess at an injection site. This is the antecubital fossa. And this was, this did get an incision and drainage in hospital. And then this young woman followed up with us for support around accessing her antibiotics, for local wound care.
Now, I take it a lot of the wound care was topical antimicrobials to, hit from surface, hit from systemic. So you were doing topical and systemic at the same time.
Yeah, and trying to manage moisture, which this was not my dressing that was taken off, but not really managing the moisture optimally.
It's and then funny, also, I saw that picture the other day. I thought, is that telephone? That doesn't absorb anything.
Yeah. With your number came up, your phone number?
Yeah.
And then also something that's durable, that it's going to stay on folks and help them help keep the wound clean for as long as possible, considering that folks are maybe not having regular access to showers or just kind of like basic hygiene stuff. So this is an example of an abscess that kind of had a more complicated course.
Yeah.
So this gentleman was kind of on the older side for our population. He was 47, and he had some comorbidities that put him at kind of greater risk for delayed wound healing.
Yeah.
And this gentleman, so this is the back of his calf, and it was a site that he was injecting into. So sometimes for folks, if they've been injecting for a long time, they may have a harder time accessing the veins in their arms just over time because of scarring. And so we'll kind of look for other sites to access veins. And so he was injecting into his calf and did develop an abscess at an injection site. And this wound really ebbed and flowed for many months. I would sort of see him for a couple of days regularly, and then I wouldn't see him, and then he'd be going to another service to get wound care and another service and kind of come back to me a few weeks later. And the wound was just constantly changing. And the thing with this particular case was that we weren't really able to implement a consistent care plan because this gentleman was accessing services in a lot of different places. So I found kind of what ended up being more successful here was really doing a lot of education with him about local wound care and why we were making the choices that we were making and what we wanted to see happening to the wound, like not just it getting smaller, but like the other characteristics that we're looking for, so that he could self-advocate when he was accessing care at other services.
Yeah, because occasionally we do say, what do you think? Exactly.
So, understanding that like abscess and cellulitis is kind of a pretty prevalent issue that we're seeing, we've tried to make some concerted efforts to address this at different kind of systemic levels. So, we do have an on-call NP, and he's been working at increasing his capacity to perform incision and drainage procedures, knowing that this is something that a service that folks need access to. And then we're hoping in the future to be able to actually provide that service on site for us as well. But then also for the nursing team, like being able to assess, is this an abscess plus or minus cellulitis? Is there a need for oral antibiotics, or can we manage this locally? So that's kind of like an education capacity for us. And then also in terms of like prevention and assembling the team, I kind of thought on this one that the community is really the team. So I connected with one of our service users who has a really good reputation for being able to hit a vein. And we got together and we co-facilitated a self-injection workshop for service users. So we talked about kind of tips and tricks for safer injection, supported people with vein finding and like how to maintain vein health. And then I also did a section on like the pathophysiology of abscesses and cellulitis. And kind of, it wasn't all information that people had necessarily received before, just like those details about how these things happen. And it was really cool because seeing in the following days and weeks, the people applying the stuff that they'd learned.
Lights came on. The lights came on. Yeah.
Absolutely. And also like sharing the information with other community members. So just kind of having like a community practice of safer injection technique.
Excellent, excellent. Now this is interesting. Just FYI to our listeners, Wound Care Canada is about to publish another BPR, best practice recommendation, and it's on MASD, moisture-associated skin damage, of which immersion foot or trench foot is one of the big problems. So this happens to be your second case. So what's the story here, Erin?
Yeah, so this gentleman came to us one day complaining of foot pain. He really wanted to take his shoes off and put his feet up because he was having a lot of foot pain, and he revealed some very macerated feet. And the story here, he was new to town and didn't have a place to stay, so he was sleeping outside. It was the summer, it was hot and muggy, it was raining a lot, and he only had one pair of shoes, which were work boots. So he was basically like in these wet socks and shoes sort of for days on end. And on this initial meeting, he also reported a history of diabetes.
Mm-hmm. Oh.
So moving ahead, when I initially met this gentleman, like going off in my brain was like diabetes, uncontrolled diabetes. And that's kind of where my focus was and where my goals were headed. But those actually weren't his, concerns on that day. Like he wanted to be comfortable. He wanted to get his feet dry. And so the interventions for that were, fairly simple. They were like new pair of shoes, dry socks, giving him a place to rest and put his feet up. And so in that sense, we really were able to meet his goals that he had. And over time, as he got to know us, he let me do a blood sugar and it was normal. And then a couple days later, I did another blood sugar and it was normal, and another normal blood sugar. So I think maybe at some point he'd been told that he gets low blood sugars or something like that. But diabetes didn't seem to actually be an active issue. And, in his own time, he did assemble his own team and connected with our nurse practitioner for some primary care. So yeah, he really led the goals in this particular scenario.
Perfect.
This is an example of a pressure injury. It's the right heel that we're looking at. And I can't say that we see a lot of pressure injuries, but this particular woman, and she had 3 pressure injuries actually. We did spend a lot of time and tried to do a lot of planning and care for this woman. So she's in her mid-50s and she'd been admitted to the hospital for a spinal abscess, which was surgically managed. And this kind of resulted in paraplegia. So she now needs a wheelchair to mobilize. And unfortunately in hospital, she developed a sacral pressure injury. And she ended up leaving hospital, like she self-discharged or left against medical advice. Because she was going into withdrawal, she just really wasn't having her opiate dependence managed well enough. So she was kind of between a rock and a hard place, and she ended up electing to leave hospital so that she could manage her pain and withdrawal. But she left hospital in a wheelchair, like just one of like kind of the hospital wheelchairs that they provide, which was obviously not the proper seating for her. And it was the middle of winter. She was having she was like wet all the time because of incontinence and also because of the weather. So unfortunately ended up developing additional pressure injuries to her right IT and right heel. And we did spend hours with her kind of doing wound care, doing brief changes. And I mean, really the wound care, like the priority was really just trying to keep her as dry and clean as possible to prevent further skin breakdown.
Did you get an OT in there? It looks like she was externally rotating. I know, you know me, externally rotating on the foot pedal.
Yeah, so that's exactly what happened. I think, if she'd been able to stay in hospital longer, and I know a lot of hospitals are doing work to try to increase their capacity to support people who use drugs on acute inpatient admissions. but yeah, they weren't able to get to the point where she could have an OT referral in hospital, which I think would have been really helpful, or PT, so that she could, you know, have a proper mobility device, maybe recover some of her mobility. But that just didn't happen. So she was in the community really without any supports, no housing. And so, you know, we did a lot of different things to try to support this woman, but like the key piece that really made all the difference was another service provider was able to get her into a transitional housing unit. And so then once she had housing, it was so much easier to do that case management, to have home care coming in to do the wound care. And I'm really happy to report that she's learning how to drive her new wheelchair right now. And that'll be a much better service for her.
So she got fitted properly for her chair.
She did.
Yeah.
And then just for fun, this is a picture that she drew for me. She's a very talented artist, amongst other things. And then, you know, this is just a picture of my wound care cupboard about like 5 seconds after I cleaned it out. And I think just the point, you know, the local wound care is really a small part. And it's really like the context of people's lives that is the key here, and how we can mobilize resources to support people to have kind of those optimal conditions for wound healing.
Yeah, and you know, one of the things I talked to you about earlier when we were discussing this is what tools do you use to assess the wound? And you know, because you've got such frequent flyers, they come and they go to different places, it's difficult to get a handle on it. But you know, one of the things you mentioned is when you're assessing, that's when you really talk to people and get to know them. And I know from my experience, a wound assessment tool slows you down enough that you can have a really good dialogue with somebody. And that's so much more important than just simply putting a dressing on something. So I commend your scope with these people. The scope is so broad.
Yeah, and I do think, you know, these services weren't necessarily always designed or funded for holistic care. So that's one of the challenges too, right? So, and something I think in harm reduction we try to advocate for is to have more of those resources, so that we can be more consistent for folks also in terms of providing support.
Okay, another question for everybody. My personal beliefs about persons who use injection drugs do not affect the care I provide. I bet you they're going to do well on this one too. All we're doing is allowing you to reflect a little bit, because that's what it's all about, is how you feel in order how you practice. So look at that, you know, and I commend some of you for saying that, yeah, there is something in there that's giving me a bit of a barrier. So let's take a look at literally the feeling. So when you think about the stigmas, what are some of the preconceived judgments that you hear out there? I mean, this is your lived experience, Erin. So how can our preconceptions make barriers that can interfere with the quality of care we can deliver?
Mm-hmm. So I think, you know, talking about stigma, and this is kind of like the guts of harm reduction. This image is actually something that we have on the wall at my workplace. And it's just a reminder that healing is not linear. It's a journey of ups and downs. And harm reduction is really about valuing and caring for people wherever they're at in their journey. And I think, you know, it's important for us to remember that people are really good at picking up on subtle cues. So they'll know if you're uncomfortable or judgmental about their drug use, and that can result in people avoiding care. So our attitudes really do matter in making sure that we're not like perpetuating stigma in the care we provide, because that in itself is a barrier to care and to good outcomes. And I think sort of like when we fundamentally and persistently misunderstand drug use, people A, do not trust us to treat them well, and B, don't trust our competence to address their issues. So what we often perceive as like resistance to care or not engaging in care is in fact sometimes people rejecting services that are not addressing their needs. And so harm reduction is really about, you know, we don't need to change the person, we need to change the system. And I think, you know, we all do want to have good outcomes, but that's really more about like our ability to do the self-reflection and affect system change.
Well, and that's part of what this webinar is about, is allowing you, I mean, I know my eyes were opened, and I know Elena, like we've been talking with Erin for a few days, and yeah, it is surprising what kind of services these people, I mean, when I go downtown Vancouver, I see so many homeless people as well, and you know that a lot of them are drug dependent as well. So yeah, I think we really need to confront those and really start looking at what is the problem. Like, is it the drugs or is it something else?
Yeah, so, and I think, you know, when we talk about someone is being stigmatized, what is actually happening is that they're being discriminated against. So, you know, we need to shift our thinking too, to like reflect our own accountability as healthcare providers. And I think when it comes to people who use injection drugs, we tend to focus all of our attention on the drug use. Like if people stop using drugs, their problems will stop. But when people experience barriers and systemic violence in many aspects of their lives, those are really the bigger issues that are causing harm. And
Yeah.
I think, you know, it's not the whole story, but there's definitely a link between trauma and substance use. And for some people, drugs are the thing that's keeping them alive and getting them through the day when they're dealing with some pretty heavy stuff.
Yeah.
So harm reduction asks us to like shift our gaze away from just the drug use to see the bigger picture. And I think, you know, for us as healthcare providers, we need to acknowledge that the system we work in systematically excludes people who use drugs and people who are homeless and people who are Indigenous and racialized from equitable access to services. So it's really that health equity piece that we need to focus on to improve outcomes.
Yeah, for sure, for sure. Last question. Ultimately, well, last question for you guys. I still have more for Erin, I'm sure. Ultimately, persons who use injection drugs need treatment in order to stop. So we're looking for solutions. Okay, what do we have, Miss Elena? Ah, very interesting. And you know what? I have to say, I'm sort of that way too. So you know, we've got 42% that say true and 58 that say false. So what is the solution, Erin? I mean, yeah, right. You've got the solution. Tell us, Erin.
Well, I mean, it certainly does beg the question, what is treatment? So
Yeah,
I think everyone's goal is different.
they're divided. That's why they're divided. What is treatment? Yeah.
Everyone's goal is different, right? So some people want to stop using drugs, some people want to decrease their use, some people don't. But I think everybody does want to reduce their risk of negative outcomes, and that's our work in harm reduction. I think, you know, that the medical community has provided some options for folks. So a couple of these might be well known to people. You know, a really common one is methadone and buprenorphine or Suboxone. And then kind of an emerging modality that's being offered by the healthcare system is safer opiate supply. So that's where short-acting hydromorphone is prescribed, and people can take it orally or they can inject it along with like usually a long-acting morphine. And both of these therapies, is there a ton of evidence for their effect on long-term abstinence? No. But there is a lot of evidence that they help reduce some of the risks. So they decrease overdose risk. They can prevent people from going into withdrawal, which can be very distressing, and just creates some stability for folks as well. But I think I did want to mention, because I think, you know, society really holds up as the gold standard still, is this idea of residential treatment. And I think that's often what people mean when they say people need treatment. And it has the goal of abstinence. But I think it's good for us to talk about and acknowledge the fact that there's really not evidence to support the long-term success of residential treatment, if that goal is abstinence. And really, residential treatment can put people at increased risk for overdose when they're discharged from these programs. And then also for folks to realize that there's no regulatory body overseeing residential treatment. So it's very inconsistent across programs.
Yeah. You have a new paper coming out the end of June in Wound Care Canada. Are you going to be addressing some of this in that paper?
I do, yeah.
Yeah.
But there's lots of good research coming out now, especially around safer opiate supply, and about like kind of rethinking what we mean when we say treatment.
Yeah, I saw the early draft of it, and you do gather some of the evidence and support some of the statements that are out there. It was an interesting paper.
Thank you. So, you know, thinking about treatment is something that we've been asked to do in Ontario. This is the whole reason that we were renamed Consumption and Treatment Services. So we've been doing some work to kind of reimagine and reframe what treatment means from a harm reduction perspective. And I think, you know, for a lot of the harm reduction community, really, it's that idea of community as treatment. So, you know, acknowledging and, you know, so the obvious truth that people are healthiest when they are supported with love and compassion by their communities. So growing and nurturing a strong community is sort of how we approach this idea. And it's not just like recovery from drugs or treatment from drugs, but also recovery from trauma and exclusion and isolation. So, oh, if you want to go back to one, Heather, for me. I think one of the most important ways that this happens at our setting is, I mentioned before that about 50% of our service users are Indigenous. So we've been very fortunate to have Les Harper and Walking Wolf, who are two knowledge keepers and Indigenous harm reduction activists, who actually host a sharing circle at our site every week. And it's for service users, but also for staff, where we come together and kind of share stories, concerns, stuff we're struggling with, and hold space for one another. And it's really like a culturally appropriate form of care for our community. But community also looks like spa days, as pictured to the left. It looks like beading workshops. It looks like doing art. So we have a lot of really amazing artists in our community who have put lots of beautiful art on our walls. And it also looks like organizing together and fighting for the things we believe in. A lot of our service users are very active in like the media, doing deputations at City Hall, and community organizations fighting for drug user rights and Indigenous rights and other issues. And so this is a photo from the National Day of Action in 2019.
Well, we've got something happening right now that's affected a lot of people. And I mean, I could talk about this too, because I know you had riots yesterday in Toronto, and we've had them in Vancouver as well for Black and Brown Rights Matter. But we've also been living through COVID with this. So you have really well addressed the Indigenous issues and how, you know, your services really are for all people. But there's a bit of a crisis here when people are self-isolating. I know we've had a few deaths out here that have made the news. I'm in Vancouver, by the way, or in BC. So how has COVID really impacted your practice there, especially around the fact that people are self-isolating and don't have that safety net?
Mm-hmm. Yeah, so I think we're definitely seeing the convergence of two crises. So there's COVID, and there's also the overdose crisis. And so, you know, across Canada, we're seeing the scaling back of harm reduction resources, or harm reduction services, and services for homeless people in kind of this effort to create physical distance. But that means that we can see fewer people a day. There are fewer places for people to go to get support. And, you know, all this focus on isolation and physical distance, like we know that the biggest risk for an overdose death is when somebody uses alone. So it's really complicated. And we're definitely very concerned for people's safety. And I think in the past 3 months, we've seen a really alarming surge in overdose deaths across Canada, kind of as a result of the changes that have happened in response to COVID.
Yeah. Very, very scary right now. Yeah. Okay, Erin, I would like you to give us, in a nutshell, some of your takeaway strategies.
Yeah, so, you know, harm reduction doesn't just take place in supervised consumption sites. It can really take place anywhere. So wherever you're providing care, I think you can integrate some of the stuff we've talked about into your work.
A little closer, Erin, a little closer to me.
That these are really philosophies and ideas and strategies that can be taken into any kind of clinical work that we're doing, not just in harm reduction settings. And my article coming out in June has goes a bit more into those kind of practical strategies that people can engage when using with people or when working with people who use drugs. And just kind of to make a note about sort of the urgency and the gravity of this work for us in harm reduction. This is a picture, or these are pictures of the memorial wall where I work. So I see this every day when I go into work. And the top picture is a photo that was taken a couple months after we opened in 2018. And the bottom photo is that same wall today. So as you can see, we've had to add a lot of photos to that wall. And I think, you know, the overdose crisis is still very much happening. And we kind of, I hope people understand that wherever we're working in the healthcare system, like we do have a role to play, because it's not just about supervised consumption services, it's about changes at kind of every level in our communities and society to really support people and prevent unnecessary deaths. But I do think it's really hopeful that we're having these conversations, and I'm really grateful for everyone who has been part of the webinar tonight. And I wanted to end on a happy note, because I really want people to understand that the place where I work it's yes, a place where people struggle, but it's also a place where there's a lot of joy. And we love to celebrate. So we love, when it's somebody's birthday, we love getting them a birthday cake and singing them a happy birthday and giving them a card that everybody signed. So just the story behind this particular birthday cake. So this gentleman, you know, we knew it was his birthday, we bought the cake, and then we were kind of waiting for him to show up all day. He wasn't showing up. And eventually, right at the end of the day, he did come. And he was telling us about how he was having a really bad day, because he'd actually been robbed kind of first thing that morning and had his money and his drugs taken. So he'd spent the whole day kind of running around trying to make some money, and was going into withdrawal, so he was very uncomfortable. And also he was just feeling sad because it was his birthday and he was missing his family. So he came to the site, he was telling us about his really bad day, and he was kind of preparing his shot, because he'd eventually made enough money to buy some fentanyl, so he came to us to do that shot. And we like lit the birthday candles and we sang him happy birthday. And he's a pretty tough guy, I would say, for the most part, but he got like a little bit choked up and he was like, "You guys, nobody had wished me a happy birthday today." And that got us pretty choked up. And I think, you know, this picture just really sums up harm reduction for me, those principles of valuing and celebrating people wherever they're at in their journey, and just really the power of community in people's lives. So I will leave you with that.
Okay. And we will leave you with this lovely saying here and open the floor for questions for Erin. So feel free to reflect on this. We have a couple more slides after this, but we would like to take questions now if anybody has. And Lena, I think you've been collecting questions in the background.
Yes, we've got lots of questions for Erin. Can you please speak more to vein finding?
Yeah, I saw that question there. And I was trying to think of a concise resource to refer people to. And I think Katie, so C-A-T-I-E, has some really good resources about around vein health and vein finding for people who use injection drugs, and stuff that's really good to kind of hand out to folks as well. Like there's a lot of different formats for the material, and just really
They can Google that?
Stuff. Yeah,
can,
so
okay, Google
C-A-T-I-E, yep.
Can you make sure that gets on the website, Elena?
Sure, absolutely.
The resource? Okay.
But I have lots of harm reduction people on the webinar, so if there's anything else that you folks would recommend.
Another question, Erin. Do you ever give your clients a written care plan to carry, or would that get lost?
Sometimes it works for some folks, doesn't work as well for other folks. I feel like we need to laminate them so that they're waterproof. But yeah, no, it's an idea. I think any way that we can promote kind of consistency in care plans is good. So yeah, it's not a bad idea.
In Calgary, we tried clinical pathways, and I'm not sure if they're still using them there or not, but the problem was they'd get lost on the bus or left in a bus shelter, and, you know, people would forget them places, but they did work when they worked.
Yeah. And it's really like, it's challenging if you're homeless to, like, your stuff isn't always safe, right? So it's hard to, you know, keep things secured sometimes.
You know, I'm thinking of our PUAP, the pressure ulcer program we had, where you have a risk action card, you know, just like a recipe card that has the risks on one side and the actions for treatment and prevention on the back. You know, a card like that might be better than like a whole care plan.
Mm-hmm.
Something they could put in their back pocket.
Yep.
Another question, Elena?
Yes, many. So how do you provide care to a person or obtain informed consent when they come into the clinic and they're under the influence of substances, they're falling unconscious, they're asleep in clinic, and they're unable to tell you if a wound or dressing change is painful or the risk of injuring?
Mm-hmm. Yeah, so I think like in a general day, like everybody I work with is under the influence of drugs. But I think there's really a wide spectrum in terms of, you know, some people can do a shot of fentanyl and like are very coherent. They absolutely know what's going on. And I sort of, consent is sort of like a case by case sort of thing, depending on, you know, do I feel confident that the person is understanding what I'm saying? Like, do I feel that they're able to put in their own perspective and talk about the challenges that they're having? So it's really a case by case and not so much whether someone's under the influence or not, right?
But that's almost what you would see sometimes in Emerge as well, right?
Yeah, absolutely.
Yeah. Just so you know, we're coming up to the top of the hour, but of course we're willing to stay on and answer as many questions as we can. We'll stay on till quarter after. So those of you that have to leave, feel free, but we're not going anywhere. Go ahead, Elena.
Okay, next question. Do you have antibiotics on hand to give out? And do you have a medical directive to order antibiotics, or do clients need to see a physician or nurse practitioner?
Yeah, so the system that we kind of have, we do have sort of a stock of common antibiotics. So we have our, you know, cephalexin and Septra and a few options. And generally what happens, either people will see the nurse practitioner when he visits, which is like once or a couple times a week. He'll come actually on site to see people. Or if someone is needing antibiotics and the nurse practitioner is not around, we can also call the nurse practitioner and kind of do an assessment together and assess the need. And then he can do orders for us that way as well.
Do you use video?
We don't, no. I think we would like to. I think, you know, that's also kind of an effect of COVID, is everybody's trying to get their IT kind of to be more flexible and responsive. So I definitely think that's in the near future.
Yeah. And Erin, are your dressings funded by public health?
They're not. So our site is operated by a community health center. So we kind of, we're under the community health center budget for our dressings. And we don't have a particular formulary, so I have a fair bit of freedom in terms of what's ordered, as long as I keep my costs reasonable.
You don't send them out to buy their dressings. They come to you to have dressings done, correct?
Yeah, and I mean, some people will have, so in Ontario, we've had the LIN system, so some people are supposed to be getting their community care at a LIN clinic, which can be kind of high barrier for some folks for a lot of different reasons. But sometimes people will be getting their wound care supplies that are funded through that model and then bring them to us to use. But mostly we're just using our own supply.
Another question here. I'm not sure if it's if there's enough detail here, Erin, but what documentation is required for your clinics?
Yeah, no, that's a good question.
Yeah, so I think different supervised consumption sites have different systems. For us, people can access the service really without giving any personal health information. So people don't have to give a legal name or their birth date or their health card number or any of that stuff. But if it's kind of moving into the territory where we're doing clinical care, and especially if that's needing to involve prescriptions or referrals, we will then start to collect some of that personal health information as people are comfortable. And then we do document in our electronic health record that's part of the community health center. But we also keep kind of an anonymous chart open for folks that we need to chart on for our own purposes, but folks who aren't necessarily comfortable giving too much personal health information. So we try to be flexible for folks depending on what works for them.
So is there a litigious aspect to this? Like, because, are these considered legal documents?
Yeah, I mean, it's in our health documentation system. Yeah.
Like, do you have a daily log?
We do for nursing care, like the nurses will document nursing care provided, but for generally just people coming in the door, they're not required.
Yeah, okay.
Mm-hmm.
So, Erin, how do you provide consistent wound care to clients that don't consistently come in?
Well, I think, that whole piece around education and having really good conversations with people about, what our goals are in terms of local wound care. People are definitely capable of taking that information and sharing it with other healthcare providers. So I think that's been a way to support people in terms of consistency. Well, it's kind of been a learning curve from our perspective as healthcare providers, but I think there are absolutely ways for people to find some consistency. It's just us figuring out where we fit into the puzzle.
Well, even in community, I mean, we had community clinics in Calgary, and consistent care is still an issue. I mean, people have to show up. If they don't show up, they don't get consistent care.
Mm-hmm.
Erin, any resources related to drug-induced vasculitis?
No, I saw this question. Not that I know of. But maybe I'll do a little search and see if I can find some resources.
Say that again. Say the question again, please.
Any resource related to drug-induced vasculitis?
No, but
Heather.
That's a good question. And you know what? We can post that one. Would you save that one too, Elena? Because many people may know responses to that. So we'll post that as a question. And we can also do a bit of a lit search as well and post it.
So, Erin, what is the most used dressing for your demographic if money is tight? What can you use stock?
I'm curious too, Erin.
I don't use a lot of the film dressings because they make wounds very mucky sometimes, especially if there's infection present. So simple stuff like non-adherent gauze is something I use a lot of. Regular gauze and sturdy tape.
And what topical preparation do you put on the wound most often?
Yeah, so we have some iodine for sure, and then we have some impregnated gauzes as well that we use. Yeah, if something's needing a bit of an extra boost.
And before everybody drops their drawers on that, the risk is very high here. And what people would say to me when we would use an antimicrobial is, we're trying to save a limb or an arm, in a very high risk person here. So getting control of it, using antimicrobials is pretty well what you have to do. And it's difficult. Some of them are very expensive, so it is difficult. But a topical antimicrobial as well as systemic for sure. Yeah. Another question?
Yep. So this, I believe, is our last question.
Okay,
Why not advocate for government funding for your medical supplies? And it also comes with a comment. I find wound care suppliers helpful, and they may provide free education and maybe free supplies possibly.
Well, this is certainly one of the benefits with being involved in Wounds Canada, is that you get well connected with the different resources that are available out there. So that's absolutely true. Why doesn't the government fund us for wound care? So, I mean, it's certainly true in Ontario that the funding packages for consumption and treatment services don't really cover a lot of that stuff we're trying to do in terms of providing primary care support or really any other kind of programming. So like that funding model fundamentally kind of excludes, you know, dressing supplies. But I think that's one thing that we are advocating for within the harm reduction community, is for more supports to be able to have those resources on site, because it is the work that we're doing.
Yeah, yeah.
And here's a good comment: contact your MPP.
Yeah,
Put
Yeah.
the pressure on.
Yeah.
yeah, put the pressure on.
Yep.
So just to close off a bit, if you have more questions or suggestions for other webinar topics, go on infowoundscanada.ca. We do get your questions and we do answer them. And also access and use Wounds Canada resources. Elena, what were the stats on the, we've got brand new, okay, so COVID came, all right? COVID came, scared the bejesus out of all of us. And what did Wounds Canada do? It started to do an at-home series to help people that were basically at home with minimal services. And if you could just tell us what the stats are from these new services, Elena.
Absolutely. So as Heather mentioned, as a result of COVID and patients not being able to seek their advice and consult from their healthcare professionals, we decided to develop this resource. It's called the Care at Home series. And we have launched 3 of those brochures: Changing Your Dressing, Pressure Injuries, and Managing Your Swollen Legs, Venous Leg Ulcers. And since we've launched, which would probably be about 4 weeks ago, we've had over 5,700 downloads. And these are all available on our website. They're available. You can go to our landing page and you can find instructions on how to download there. And please feel free to use and to distribute.
Now we have 2 more coming. We've got the diabetic foot. We've got foot care, like basic foot care, and we've got MASD, which is moisture associated skin damage, those, and surgical. So there's 4 new ones that are going to be released in the next couple weeks. And also our BPRs, the best practice recommendations, the peripheral arterial ulcer one just came out. And how many downloads for it already?
For that one, we have 3,365 downloads, and that just came out just under 2 weeks ago.
Yeah,
so again,
MASD is on its way.
Yes,
yeah.
And again, if you visit our landing page, woundscanada.ca, there you can easily get access to them and download them.
Yeah, and what's coming down for those, because they're long documents, I'll warn you right now, they're long. We're bringing out BPR briefs, which are like, what's that book? Cole's Notes, like Cole's Notes. So they're like 15 pages. Yeah, some of them are short, some of them are long. And then, of course, for unregulated care providers, because we have so many family members caring for their loved ones at home, there is an online course that you can take as well. And then, Elena, you want to talk briefly about membership?
Yes, definitely. So a shout out to everyone to please consider becoming a member of Wounds Canada. You've heard this engaging presentation, and there's more to come this year. So please visit again our website. In the top navigation, become a member. You have access to an image bank, a video gallery, our archive poster presentations. They're all on our members portal. It's password protected. You'll receive quarterly newsletters, discounts on our professional educational programs, and discounts on our wound care tools and resources sold in our e-boutique. And for the low price of $50 a year for students, retirees, patients, or lay caregivers, or $100 for an individual membership. So certainly please do visit our website and consider it. And as well, I just want to make a note that we will be sending all of you a survey, and please complete that. We'd love to get your feedback, and we also would love ideas for future webinars. This particular webinar is being recorded and will be archived, and it'll be archived on the members portal site, which is another reason to please consider getting a membership, because you can come back to this recording and view it again, as well as view as other webinars. So thank you for joining us.
I'd like to thank everybody, Erin, especially you and Elena, for manning the fort. And I want to leave you with a thought. Dr. Bonnie Henry in BC, and I know some of you are from here, says, be kind, be calm, and be safe. And for those of you that know me and have known my teaching for the past God knows how long, I looked at that and I thought, hey, that's my B's. I used to have B's on my final slide, so I put them back. The B's mean be inspired, be challenged, and be true. And then my husband says, because I was traveling all over, not just this country, but everywhere, he said, wait a minute, you're missing a B. Be careful. So please, everybody, thank you so much. And as we continue with this COVID journey, be kind, be calm, and be safe. Take care.